This morning I'm going to take you through the Belmont hypothermia pump. We're going to start, of course, with the pump itself. We're going to open this door and we're going to go through the loading components. With your standard kit that comes in a box that looks just like this, the label should read 902-00045. So I think you may have some here that are still 37s. If you do, get rid of them. You won't like them, and these are much, much better. So with these kits, we have three components. The first component is our heat exchanger, right here. And your label is right here. So if you're looking for your lot codes, they're here. Expiration dates are here. Usually this will be one of three numbers that you'll record during the case. The second is for your table pack. We'll go through the contents of the table pack in a second, but right here are your numbers as well. And then the third component is your reservoir. Again, you'll find that your numbers are right here on the top. So the way that I like to do it is we'll start with the heat exchanger. We'll come right over here and pull this open. And it looks just like this. So we're going to take off that blue tape so we have access, and we'll pull this right out. Now if you notice, with your hypothermia pump, you have red and blue pathways and you have red and blue tubing. So we're just going to start by putting in our heating ring, red arrow up. Now you'll notice this in the middle is your heating element. This is your magnet. This magnet is going to heat these 16 stainless steel rings. That's how we're achieving our heating. And because of that, the temperature will heat very quickly and also very evenly, very accurately. So the temperature that you see on the screen is going to be the temperature that you're actually delivering to your patient. So we're going to pop this in, and this pressure chamber goes right into this notch right here, and just below this is your air detector. So we're going to press that patient line into the air detector. If it's not in that air detector all the way, it may be reading false air alerts. So if you continue to get air alerts in the system, it could be because this tube is not pressed into this air detector here. So we're just going to take this blue tube, bring it around here, and you'll see that this has a blue arrow up top. So this blue arrow points right into this notch. Before we close up, we're just going to make sure this blue tube is in this blue canal. If it's not, you're going to get something called a pump fault. So if your screen is telling you have a pump fault, it's because this tube has ended up outside this blue reservoir. So we're going to tuck this in, and everything we can pat right into place and close up, just like that. So from here, the next thing we're going to do is connect our reservoir. So that's found in this box. We'll open this up. And you'll also find that your reservoir is labeled as well. So this is a 4.4 liter reservoir. We'll pull that out right here. And you'll notice on top, each port is labeled. So we'll pull out our spikes. And the first spike we have, this is our medication port. So we'll remove this black cap, and right here where it says medication, that's our first spike. If your chemo is pre-mixed, which it is here at Maine Medical, then you will probably never use that port. What you will use is right here, sterile solution. We'll pull that off. And we're going to add our spikes to our sterile solution port. And then we also have our vacuum tube. You'll notice on your vacuum tube, it has arrows. The arrows are pointing from the reservoir to your vacuum unit. So, we're going to take your cap off here and right here. This is your vacuum release valve. That's your pressure valve right here. So we're not going to touch this. I have connected the vacuum to that valve before, and it doesn't work. So if you're finding that you have no suction, double check, just make sure you're connected to the right port. So we're going to take our reservoir and drop it right into our ring. Then we'll raise that up. And you'll notice here, we have two lure locks on the bottom here. So we're just going to drop this down, and these have a clear cap. We'll remove that. And we're just going to connect the two lure locks together. There's one, and each one of these is capped off. And two. So now your reservoir is in place, and the next thing we're going to do is prime our unit. So we're going to come right to the back and turn it on. While we're doing this, we're going to take this vacuum tube, take our cap off the top, and this vacuum tube is going to run to your bottom receptacle here. So if you can see this, and then this will be connected to the wall. So this is going to be your wall section. And here at Maine Medical, you do need a tube to connect this to the wall. So the first screen that comes up is going to be right here. It says for hypothermic treatment only. The reason we say that is because we have a rapid infuser that looks just like this. So we certainly wouldn't want anybody using this for rapid infusion, because while the rapid infuser heats to 37.5 automatically, this has a temperature that you can change. So it's just letting you know that this is a hypothermia pump. We're going to agree to that. And then here our password, our secret password, is a series of 6 ones. And that's going to send the machine into its quick diagnostic. And then it's going to bring up your first screen, which is connect your fluid lines, connect lines, connect fluid bags, and hit prime. So we're going to take our fluid. And we'll hang here. And we're going to spike.
Can we prime with ringers?
We primed with ringers yesterday, but it's not uncommon for surgeons to also use Normasol or normal saline. So we're going to spike our fluid, let it run, and we're just going to hit prime. So you'll see as this countdown is heading towards 0 and this is flashing, that means we've done everything right. The machine is priming. So what we're doing is we're putting 100 mLs of fluid into this circuit. All that air is getting pushed out here at the top of your reservoir. So now that we're fully primed here, it's going to ask us to prime our patient line. But our patient line is not attached yet. We're not going to attach our patient line until we get it back from the sterile field after the cannula have been placed by the doctor. So now we're going to go through our table pack. So our table pack, this will be going to the surgical tech or to the doctor. You'll see it's labeled here, and it consists of your inflow and outflow cannula right here. This is your inflow and outflow tubing. And your temperature probes. These are your free-floating temperature probes. So you have the ability to run 4 different temperatures. And you'll see here, as when we go through our tubing, that this is made up of to your table, this is going to be your inflow and outflow here. Now you'll see on these lines, you also have arrows. So this is your return, and your inflow is on the other side. So you'll see here, inside these tubes are your temp probes for your inflow and outflow. So these are going to be T1 on your inflow, T2 on your outflow. And then this is what's going to get returned. We'll go through that in just a second. So now we're going to go through the cannula. And these get pulled out right here. So you have 2 inflow sumps, 2 vacuums, and 2 wide tubings here. So each wide tubing has arrows on them. These arrows are indicating this is your inflow. These arrows are indicating this is your return. On your return, we're going to use our 2 vacuum sumps. And they just get placed right on the end, just like that. Your inflow is right here. And we have 2 inflow cannula right here. Now, here at Maine Medical, Dr. Redstein will put these through 2, I guess you can call them stab wounds on either side of the belly. So she's putting those through, and then she's going to be connecting this, but she will place these first and then connect them to your Y connector here. So from here, the next thing we're going to do is we are going to connect our inflow and outflow. So right here, we'll split that up.
And these are passed off from the table?
These are actually connected at the table.
Yeah.
So this is something that will be done by the surgical staff.
Gotcha.
So you'll see in each case, they have clear caps on them, but you have male, female, male, female. So you can't hook them up backwards. And we'll connect these as well. Now you have your inflow and outflow placed. Once these are placed, this end will be returned from the field. So when we receive this end, first thing we're going to do is this is our inflow line right here. Blue cap. So we're going to take our inflow line and connect it right here. Obviously we want to make sure that lure lock is tight. And the next thing we're going to do is take this end, which is going to be our return. Our return consists of 2 different tubes. So this is going to be what we use for our rinse. We're just going to clamp this off because right now we're going to be using our return. So for this return, we're just going to uncap here, and right on top of this you see a port that says patient return. So we're going to connect this here, and as this is running, this is normally going to run at about 41 degrees. As we're doing this tubing is going to get a little soft and it's going to start to sag. What we recommend is just simply taking this tube and running it over, say this vacuum release, or in some cases you can have a hook or something in place there, but this seems to work pretty well. So we can just drape that right over that, and that's going to keep that tube in good shape. So the next thing we're going to do is prime our patient line. To do that, I'm going to take off these two cannulas so we can have a closed circuit. Obviously this isn't something you'll be doing, but we're going to close that up, and the next thing we're going to do is hit patient line prime. So you'll see it's now going to start to push all that fluid towards your patient. Once that inflow reaches your patient, you can now hit stop and perfuse. And now you're running. So for the most part, this will be run at a full liter per minute. So the first thing we're going to do is just hit that 1000 ml per minute rate. And you'll see right here is your rate. This is going to start to gear up to that liter per minute. And you'll see our return at this point won't be engaged. It is returning now, but normally what we're going to be doing right now is filling the belly. So for most cases, you're going to find that your return is going to be, your fill is going to be anywhere between 2 to 3 liters, depending on the size of the patient. And so as we're filling here, we're also going to now set our temp. So these two are your up and down temps. If I hold down the top one, I can read the bottom, or vice versa. So what we're going to do is set it at about 45 degrees. And what that's going to do is elevate the tissue temperature of the patient. For the most part, you're not going to be dropping your chemo until the patient's temp gets to about 38 to 39 degrees. I believe Dr. Epstein likes 38.5. So we're going to wait until our target temp, which is going to be either T3 or T4, gets to that level. Now, we have 4 different temp connectors. So you have red, blue, green, and yellow. Red is always going to be T1, which connects right here. This is going to read the inflow temperature to your patient. Blue is always going to be T2. That's going to read your return line. Those are both built in. T3 will be one of these placed, and T4 as well. These are usually put towards the abdominal wall. So from here, we're going to insert our temp probes right here, T1, T2, T3, and T4. So I'm just going to take that temp probe, put it in at T3, and those will be connected. Get that out. And that connects just like that. So from here, we're going to be reading our temp probes here. In fact, you know what I can do? We'll hook this up to our inflow, and now you're going to be able to read what your inflow temperature was. So once we get to temperature, we're now going to drop our chemotherapy. So from here, we're going to take one of our spikes, spike our chemo bag, let that all release in, and then we'll clamp that off. Now, for the chemotherapy, In most HIPEC cases, you're going to find that they're using mitomycin, usually in a 30 milligram quantity run for 60 minutes, followed by a 10 milligram quantity run for the additional 30 minutes following, for a total of 90 minutes. While that's being run, then you're going to see either doctor, surgical tech, what have you, agitating the belly as this is being perfused. During that agitation, you may see changes in your inflow right here. This is measuring your line pressure. So your line pressure is telling us how hard that machine is pushing to get the fluid into your patient. If that line pressure is under 180 millimeters mercury, then that's a nice comfortable inflow. Once it gets up over 200, then it will, obviously it's going to continue to push, but it may be forcing it in a little bit harder. So your return might actually be greater than what you're pushing in at. Now, if in some cases that inflow gets up over 300 millimeters mercury, it's going to start backing that rate down. So to demonstrate that, I'm going to take this patient line and pinch it off. So you'll see that line pressure is starting to climb. Once that line pressure gets over 300, you see how that rate's backing down? So it's self-adjusting, so you're not applying too much pressure to your inflow. But for the most part, you won't see that. Your biggest obstacle may be your return. The return can be impeded by a few different things. You may have anything that ends up in the line.
I think you forgot to mention the presetting of the vacuum.
Yep, we're definitely going to do that. Yep, and you're right, I should have done that earlier. Yep. So,
In terms of the sequence.
absolutely. No, and Mike's absolutely right. So, before we start, even before we connect to the patient, one of the things we're going to want to do, and I don't have a vacuum here, so it's going to be hard for me to simulate that. But once you're connected, then first thing you want to do is turn on your regulator, set your regulator at -40, and then you can turn it off. The reason being is that you know where it's set, so when you engage your vacuum for your return, then you're not going to grab the bowels or anything near the vacuum, near the outflow. So we can preset that at -40, and then we just simply turn it off again because we haven't engaged our return yet. So once we have filled, we're now going to engage our return. Once we're at that 3 liters, the belly's full, we're now going to open up this line because normally we would have it clamped off. Once we do that and we come up here to turn our regulator on, we're now going to get return from the patient. And that's going to be what creates the circuit that's going to allow us to continue heating and flowing into the patient. So once we have engaged that vacuum and gotten the return, you're going to find that we should be able to have a nice comfortable balance somewhere around 400 to 600 milliliters in your tank. That's really what we want to try to keep in. We want to try to keep as much inside the patient as possible because that's where we're going to do the most good. So from here, once we're getting our return, you're going to find that there may be a few things that impede that line. You could have any mucin that's in the patient creating a clotting on the wall. If that's the case, a shake will usually release that fluid and get your volume back up in your tank. But you also might find that your return cannula can sometimes get bent or kinked when it's inside the patient, or for patients that are larger, you might find that these get squeezed up against the abdominal wall. If you find that your return is getting more difficult, we always want to try to keep our vacuum settings below 100. So if you find that even at 100 you're still losing volume here, one of the things we can do is come over here and drop our rate down. So we're balancing that return versus the outflow to your patient. And in doing so, we're actually still going to be able to maintain temperature. So for a lot of physicians, they think that faster flow means better stabilization of temperature. That's not going to be the case here because we are using the electromagnetic induction heating. Instead of a water bath system, we're actually able to heat to temp even at lower flow rates. So we'll push that back up. So now, after 90 minutes, we are ready to drain. So we're going to drain using 3 bags. Normally you'd find 3 bags. Sometimes it may be more, maybe less. In some cases, some doctors choose to not drain the chemotherapy out at all. But what we're going to do to drain is when we are ready to stop, we're just going to clamp this off, and I had to stop that. So we're going to clamp this off, and this will be connected to your receptacle. In this case at Maine Medical, you're using the Neptune. It's a great system. So the Neptune would be run underneath the table and connected right here. And once we're connected, we're just going to release this. This is going to be clamped off. Your vacuum is going to be shut off. So now, as this machine is pumping in your rinse, which will be that 3 liters of lactated ringers or what have you, all of this is going to be flowing into the Neptune. And once you reach the bottom, then just simply shut your machine off. At this point, we'll disconnect our temp probes, and all of this can be disconnected here from the vacuum right up top. You can see that. We'll pop open our machine here, and once we've received our cannula back from the table, all of this can be dropped into a receptacle here, a yellow bucket, and we can remove our heat exchanger, and now our reservoir. And once this is out, all of this can go right in your tank. We'll close this up, and now you're done.